Hello, everyone. Welcome to our next installment of Wound Care Wednesday. It's been a few weeks since we posted our last episode. So today we have the honor of talking with Dr. Chuck Stemple, formerly the longtime medical director of Humana, now consulting and also graciously serving as our in-house medical director at JDL Access. Dr. Stemple and I are actually serving on a panel together at the Advanced Wound Care Conference in July. So we thought we'd use this time to introduce the topic of finding common ground between payers, providers, and manufacturers around the utilization of skin substitutes for wound care. So we hope to see others at the conference. Look forward to a deeper discussion on this topic there. But we thought we would just dive in with Dr. Stemple introducing himself, and then I'll let Danielle do the same, and then we'll dive right in. So Dr. Stemple, give us a little background on you.
Yeah. Well, hello to everyone, and thanks for the opportunity to participate. So I'm an ER physician by training, so did ER medicine, and then 10 years with United Healthcare and 16 years with Humana. And I think I'm part of this discussion today. In my last 10 years at Humana, I ran the clinical policy team, so obviously involved with all coverage decisions for anything and everything. And this particular space, it seemed every week there's a new product coming to the marketplace within the cellular matrix space. So it was quite a interesting and challenging place to try to look at all the various products, and I'm sure we'll get into it, differentiating the products one from the other, et cetera, et cetera. So a fun place to be in, not so much fun because you had so many different people coming at you for coverage and reimbursement and things, but really enjoyed my time at Humana. And then, as Kim says, I've been doing independent consulting now for about 10 years. 10 years, sorry, 2 years. So, and
it feels
broadly,
like 10 years.
Yeah, exactly. And consulting, broadly with pharma, device manufacturers, et cetera, et cetera. So pretty much broadly anything within the clinical medical space.
Great. We're lucky to have you here, Dr. Stemple. Thank you. Danielle, you want to take a minute?
Yeah, absolutely. So hi, everyone. Again, I'm Danielle Bargull. I'm the senior manager here at JDL Access, and I have been in the wonderful world of wound care for a little over 12 years. Extremely experienced in the payer policies and what we need and what we don't need. And that's what we're going to dive into a little bit more today, so that we can give everybody a little bit of a better understanding. Happy to answer any questions after this as well. Contact information will be up. Please feel free to call anytime with any questions.
Great, thank you. And I'm Kim Norton. I'm the CEO of JDL Access, just here to facilitate and, as I said, participate in this panel in July. So, Dr. Stemple, let's dive in. I want to start with the elephant in the room. The latest push by the Medicare administrative contractors to draft very conservative LCDs, local coverage determinations. It seems that we can glean from that payers, I'm using Medicare as an example, believe there's an issue with potential overutilization of wound care treatments by providers. So what do you think's at the heart of that issue?
Well, it's very difficult for us as a health plan. We worked for years and years and years trying to look at wound care and establish protocols. And as you know, the variety of individuals treating wounds. I mean, obviously, you have vascular surgeons, you have podiatrists, you have wound clinics. And so there's just a huge diversity of clinical skills, knowledge, experience in treating wounds. And so is the sense that due to the variety of physicians treating wounds, that there is no good standard approach that most physicians follow. They sort of, by their own education, they decide to use this product, use that product, to provide whatever. And yes, so our sense is that because we very difficult, as you can imagine, the thousands of physicians treating wounds and trying to oversee that management, there is a sense, yes, that too much product is used too often, too frequently, perhaps lack of knowledge of some physicians, inappropriate use of the products. And I think it's a space where health plans now have, as you said, with all the new products, I don't know how many total products are in the marketplace now, but trying to manage appropriate use of all the various products in all the various spaces it's just challenging to do, but I do think there's clear opportunity for us to, assess various practices and look at their utilization and cost of the wound products that's used by that practice. So profiling physicians and groups and wound clinics, I think there is an opportunity, as you said, for physicians, manufacturers, and health plans to try to aggregate together to try to figure out an appropriate approach, treatment protocol, et cetera, because I do not believe it exists today. And generally, and Danielle can speak to speak to it also. I think it's just each physician sort of has his or her own approach, and there's a huge opportunity for guidelines and protocols and standardization of treatment approach, because today I think it's just sort of scattered to the wind, and a physician does what they want to do, and we as health plans, trying to monitor utilization, patient by patient by patient. You can just imagine very onerous to try to get in that space. So if we're trying to create tighter policies, quote unquote, we can create the policies, but then can we really, I hate to use the word enforce, but see that those policies are adhered to by physicians, or obviously if physicians disagree with the policies, obviously listen to their concerns and issues. But creating a policy is something we can all do, but then how do we monitor the utilization of the product and ensure appropriate utilization? And Danielle, I don't know if you have anything in that space to add about the diversity of care that different patients receive and lack of uniform approaches would be the best way for me to characterize it.
Yeah, Kim and I definitely discussed that as well. I have quite a few ideas that I would love to kind of throw out there, especially with the way we talked about it being more of a conservative, going from 10 applications in a 12-week period down to the 4 applications, maybe putting something in place that for prior authorization purposes, if we do the prior authorization requesting the first 4, monitoring the process of the wound, depending on what the wound is and what the classifications of the wound were. We know DFUs, VLUs, things like that were covered. But after the first 4 applications, maybe going back and doing measurements to determine whether additional applications are needed and can be used, versus giving the 10 right off the bat. And then there being the waste of the skin substitutes, which is what the big conversation is. Are these providers and facilities are requesting the applications and requesting a one size, but then as the wound heals, the size is obviously getting smaller, so we don't need that full size graft anymore. So using the proper graft sizes as the wound heals to hopefully prevent less, waste, basically.
Yeah, and in this day of digitized medicine, years ago, to your point, we looked at trying to get measurements so we could assess, is the wound healing, is it closing, what's the appropriate, and just trying to get that data from the practice or the physician, and then if you see it's not healing, what's the proper approach to take? And so just a lot of time and things, but you would think in this digital age now that we should have some optics on the wound and the progression of that wound and its healing occurring, or closure occurring in the appropriate, timely fashion, or do we need to reconsider the approach to that particular wound because it's just not responding to the therapy? And that's where I think the huge gap is in a collaboration between physicians and health plans, and exactly how would we monitor the treatment, how would we monitor the response. To your point, if we give an initial short-term authorization, then chasing down the data at whatever appropriate time frame. So all those steps to put in place, just you can imagine some physicians may not appreciate us overseeing their day-to-day approach to wound care, but I do think it's clearly a space of overutilization, waste, potential for better monitoring, potential obviously for less utilization of products, potential for therefore overall cost savings at the end of the day.
Yeah, it seems like a good compromise versus just cutting patients off at 4 treatments, right?
Exactly.
I mean, there has to be some give and take here.
Yeah,
I like that idea.
Yeah, so like where can we meet in the middle,
Well, we got to meet more on the health plan side. We got to run things a little bit. But yeah, if we get the protocol out there and get agreement and as I said, just getting the data about the progress of that wound, I just see as being the largest challenge. And if the manufacturers, however, the manufacturers would work with us and physicians to, monitor the wounds and get that data and show that appropriate healing or closure is occurring in appropriate time frame, and therefore provide, yes, approval for more materials, more wound products to be used. So,
With that said, I think that's one of the issues too, is worrying about that time frame, knowing that you're already in the process of treating the patient, and now all of a sudden you have to turn around and submit another authorization to get the additional grafts approved. How long is that going to take to get that approval? Since the patient's receiving grafts maybe once a week, how fast are
yeah.
we going to be able to get that turnaround time with the insurance plan to, let's say, approve an additional 2 to 4 to 6?
And I think, just like in the genetics world, we had certain medical directors that all they did was genetic reviews, et cetera. So I think if this really is a true opportunity, I think health plans should be able to build a dedicated team, just like transplant, a dedicated team, genetics. Well, does wound care become an area of specialization by certain nurses and health plan medical directors? And therefore, they have the knowledge, they can turn around those requests quickly, et cetera. So I think the future of Medicare Advantage plans, if they get more interested in overlooking this area, having a specialized team where all these requests would come into, understanding the timeliness of the response, et cetera, et cetera. And that way you have a coordinated response from the health plan back to the physician or treating provider, and consistency of how we approach different wounds, et cetera, et cetera.
That would be awesome.
I love it. Dr. Stemple, I was looking at the Humana policies on skin substitutes, and it looks like a lot of the policies are focused favorably on the older technologies. Is that just because there's more long-term data on those technologies? Is that because of more transparent cost information? How do some of the newer technologies potentially get onto those coverage policies favorably?
Yeah, and like I said, there's been such a growth, of products in the space, and as you say, to keep up with timely review of all the new products coming to market. And I assume most individuals know that we, like other health plans, use independent tech assessment entities such as ECRI and Hayes and UpToDate and MCG Middleman Care Guidelines. And to your point, sometimes it just takes more time for those products to establish, the evidence and real world evidence and utilization, et cetera. So, and we have so many products, not to say that there's not an urgency to look at the new products, but for new products to get into the policy world, they do now need to have probably not better studies, more comprehensive studies than maybe what was out there before, because we do have so many variable products today. So I think to your point, things that have been well established, Apligraf, they've been out there for years and years and years, and have an established standard of care. And now the new to market products really need to have good studies to show, is there an advantage to that product? Does it perform equal to, the standard of care product? So I think there is a little heavier clinical burden on the new products coming to market today, and really establishing that foothold with health plans to demonstrate the benefit of the new products. And it's always the so what unmet need. So a new product enters the marketplace, I think if manufacturers can really identify, are they equal to the others? Do they feel they have a specific subpopulation, specific space that they feel their product affords a benefit? Because otherwise, yes, we're probably going to add the products eventually, but it's going to take time for that to happen. So as much as the manufacturers can differentiate their product, it really helps a health plan to say, oh, this product is adding A, B, or C benefit to the current treatment paradigm.
I think you bring up a really good point that a lot of manufacturers don't think about, which is to be a little more focused in their studies, even though it narrows their market a bit. in order to get into those policies in a positive way so that over time they can expand the policies as opposed to trying to, eat the elephant in one bite.
Yeah. So it's all about the clinical I call it clinical utility. And, to exactly to your point, if they can get, established in a space, an area, a particular type of wound, and then I call it the foothold. You've gotten coverage for this particular type of wound, etc. And then as time moves on, then that policy expands and the product has more broad coverage. So targeting an area where the manufacturer really thinks this product is going to afford a benefit would really help that company to get coverage because they've brought to market a product where they've clearly shown this is adding a clinical benefit compared to the other products potentially available.
Interesting. Danielle, anything you want to add or ask about that? Okay, so let's talk about utilization control. I think we touched on it a little bit in our earlier discussion, but obviously there's limiting to number of treatments, there's prior authorization, there's outsourcing to third-party benefit managers, all sorts of things. But I think part of it too must come down to documentation and how well providers are documenting things for those approvals. As Danielle said, even with her idea, you've got to document the need for those first 4 treatments, but then also what's happening with the patient going forward. Do you have any suggestions or advice to providers about how to improve documentation in order to maybe facilitate easier approvals?
Yeah, so I sort of mentioned it earlier when we looked at this, good grief, 6 or 7 or 8 years ago, and just the diversity of different physicians treating wounds. So as I said, you'll have podiatrists, vascular surgeons, PCPs, whatever. And so when we actually tried to develop a standard, sort of like a physical therapy report, what's happening with the wound, what, to Danielle's point, measurements, what products being used, etc. And just our ability to get uptake of that quote unquote standardized form, just because the diversity of physicians and everybody sort of had their own toolkit that they would use. And we just basically found it literally impossible to try to get uptake and adoption. And, you get a prior auth and you approve, and then that patient is off. And, maybe the PCP is treating the patient initially, then they're not doing well. So they send them off to a vascular surgeon or to a wound clinic. So the patient moves from physician to group to group to group, different areas, and those hard to treat wounds end up, who knows where they end up.
Yeah.
So the biggest issue for us was, to your point, here's the patient, here's the wound, here's the initial treatment approach. If we could standardize that among with the manufacturers, with physicians, with the specialists in the area. And then, as I said, it's sort of like a skilled nursing facility. Give us a monthly report. And if we could agree, maybe this is a topic for the wound conference in the summer. What kind of standardization of reporting could we potentially create so that across the universe of wounds, we're adopting a standardized format for that reporting? And then, could that be auto-filled through AI, through electronic monitoring, whatever way? But I think whoever out there is a brilliant mind to really create a standardized form that would be acceptable to physicians, not be too onerous to complete. But I think that's where we need to go. And until we get there, there's going to be this constant back and forth between health plans and physicians in the appropriate approach and treatment of wounds.
Yeah.
For Danielle, I don't know your thoughts, but I think it's just a space where, well, I've said it enough, standardization of approach is just seemingly lacking in all the years that we tried to look in this space.
Yeah, couldn't agree more.
Agreed.
I was talking to one of the other manufacturers who is going to be on our panel, Dr. Stemple, and he must have said standardization 60 times. So I think that's going to be the focus.
It's going to be the buzzword for sure.
And what a great use of AI. to your point.
And there's well, I've said it, so many different physician groups and types. How do we get the vascular surgeons to agree with the podiatrist, to agree with the PCP, to agree with the wound clinic? So it's a sort of a unique space if you think of all the different parties that would have a vested interest in, quote, a treatment protocol or treatment guideline. And how do you get all that diversity of those various groups together to align on a standardized approach? And that was our greatest difficulty. You could get one group of physicians maybe to agree, okay, we can work with this. Yes, this makes sense. And then you take it to another group and it just gets rejected outright because they don't
Right.
believe it's correct, et cetera, et cetera. So trying to get that a standardized adopted approach. Well, you already said it.
Yeah.
We've said it.
Yeah.
We're going to say it time and time again that's the critical need, I think, in this area.
But the alternative is onerous, policies, medical policies, or negative coverage policies. So
Exactly. And
we have to compromise somewhere along the way around some of those issues, and I think find some common ground.
Yep, definitely.
Okay. I just wanted to circle back before we finish. A quick question about what you mentioned about clinical trials. Do you think payers are becoming more open to real world evidence, or do you think it still has to be about RCTs, or both?
Well, I think we're becoming very open to real world as long, as it's peer reviewed, published. So it has to have we're only going to take real world evidence. Manufacturers, Danielle's probably had this experience. Different manufacturers would come to me and say, well, our product has, less frequent application. It's a smaller application. So overall net cost is going to be less if you use this product versus that product. So if you generate real world evidence about that, and it's standardized and it's collected appropriately and it's published, I think real world is sometimes better than the clinical trial because how is this actually being used? And if a manufacturer is making a claim or trying to come to me and say, well, we should be the preferred product because net our cost of treating a wound is X% less. Well, that's where the real world would come in and really demonstrate that that's occurring. Because I don't know, and trying to monitor that treatment protocol and how much product are they using and how big was the wound and the amount of product, was that appropriate? So all those things that could be verified through real world would greatly help support a product. And I think manufacturers understand that our policies, we cover lots of the products. We're not in a space to have a preferential product, so it's not like a pharmacy where you have a preferred product and then non-preferred. But I think the real world evidence, if it clearly identified a particular product that was delivering better results, outcomes at net cost savings, the opportunity for a health plan to work towards identifying the best product for endorsement support, et cetera, that's where the real world would fit. Because clinical trials, they're generally short term. Obviously, they're well controlled. Obviously, the manufacturer has a vested interest in, and you're getting the best outcomes in a clinical trial just because of the oversight of the care that's being given. And the real world then gives you that real world to see, did the product deliver the outcomes as it did in the clinical trial?
Yeah, I like that approach. That's great. Before we wrap up, anything else to add, Dr. Stemple, that I didn't ask or that you wanted to note?
No, I think it's a wide open space now for as we've been talking about, for physicians, physician groups, manufacturers, health plans to really, and as I said, hopefully at this conference that we'll all be at, that opportunity to develop a collaborative work group going forward and really look in the space and what is the opportunities and where can we go and how do we get all the different physician groups to support an initiative in this world, because we know I think care is different. Well, we said it. Care is different physician to physician, and I personally think if you take a wound and give it to 10 different physicians, it's going to get treated 10 different ways. And so
Mm-hmm.
I think just that opportunity to have case reports and case studies and case files and treatment approaches, well, I've said it, to standardize. I think that it's just a huge opportunity that should have happened a long time ago. And so maybe we're finally at that point in time where we can build that collaborative group and have integration of a standardized kind of protocol that allows best outcomes for our patients.
Yeah, I like that. Maybe we can try to push that a little bit more at the panel too.
Yep.
Danielle, anything else you want to add?
No, just thank you so much for your time.
Yes, thank you so much, Dr. Stemple. Thank you, Danielle. Thanks everyone for being here. Hope to see you at the conference in July, everyone. And please reach out to us if you have questions or would like to ask Dr. Stemple anything about what we just talked about, or certainly anything else in general.
Yep.
But thank you. Thank you all for being here. Really appreciate you. And we'll see you in July.
Thank you.